Our next speaker is Mr. Steve Thompson, who is Vice President Supply Chain Innovation for Cardinal Health. As a Lean Six Sigma Master Black Belt, he works with healthcare providers, medical product and device manufacturers to improve efficiencies and lower costs. Since joining Cardinal Health in 2006, Mr. Thompson has developed customized supply chain solutions for medical distribution, pre-source products and services, and the pharmaceutical technologies manufacturing business. As a result, hospitals have more precise visibility over the use of products and devices. They are able to connect purchasing to utilization and reduce the time that clinicians spend managing and tracking supplies. Mr. Thompson builds on more than 2 decades of supply chain management experience in the automotive sector. He began his career at General Motors of Canada and Delphi Automotive Systems, assigned to one of GM's first lean enterprise facilities. Mr. Thompson later worked in supply chain management and manufacturing with Lear Corporation. Mr. Thompson.
Thank you. Well, good morning. Beautiful day in Virginia. I got to tell you, is Jeremy still here? I really enjoyed that because he talks about a lot of the things that I find particularly interesting as well. Cardinal Health, as you know, is a Fortune 25 company. We also have lobbyists that are in Washington, and we come at it from a slightly different perspective. Clearly, if you don't get paid, we don't get paid. So your health is my most important thought every day. But when we talk about things like the Affordable Care Act, and we talk about what I'll talk about in a few minutes, the Unique Device Identification Law, I think it's important to recognize what's one of the things that's going on in the background. Jeremy talked a lot about Medicaid. I want to talk a little more about Medicare. So in 1965, the Johnson administration enacted Medicare. In 1965, and it's really not clear what the numbers were then, somewhere between 5.4 and 7.2 people working for every person retired. And you don't really get those numbers until people start to contribute to their Medicare tax through payroll deductions. So in 1965, 7.2 people working for every person retired, median life expectancy of 71. Let's leap forward to today. So today we have 3.2 people working for every person retired, median life expectancy of 79, and 10 million Americans over the age of 80, and 10,000 people turning 65 every day. This is a phenomenon which started about 12 months ago. Let's leap forward to 2022. 2022 is when the actuaries believe that the money, quote unquote, runs out. So when that happens, just so you know, there's no account, by the way. There's no special account that you put your money into, like your 401k. That doesn't happen for your health care, for Medicare. It went into general coffers and it paid for stuff, right? In 2022, there'll be 2.3 people working for every person retired. Median life expectancy is targeted to be somewhere around 82. And the 10 million will have doubled. So we'll have over 20 million people over the age of 80. Leap forward to 2026. By 2026, over 20% of our population will be over the age of 65. So it's not a political problem, it's a mathematical problem, right? It's a Ponzi scheme, right? Think about it. Now, I don't believe in 1965 that anyone had ill intent. If you put yourself in that position, in 1965, you could have never imagined that the economics of the world would have changed the way it has. I wouldn't think that you'd think that people are going to live 10 years longer than they do. And just the advances in medical science to be able for preservation of life is incredible. On top of that, and this is why we look at it from the Medicare perspective primarily, as you know, 90% of your expenditure in your life is in the first and your last year of life for your healthcare expenditure. So that's why this is so critically important. I grew up in a Lean Six Sigma world. I used to idolize a guy named Deming. I know, it's kind of nerdy, right? But Deming was the guy who basically started statistical process control, which led to what we call Six Sigma. Deming's quote was, look, without facts and data, you just have an opinion. And so we look at it from a much more factual and data standpoint. My concern is that as the folks who are continuing to turn 65, as that population grows and grows and grows, is the fact that Money Magazine a couple weeks ago, doing an actuary's forward-looking view, believes that by 2025, 2026, we're going to start seeing an annual decrease in our economic growth, as the folks who normally would be contributing to 401ks, et cetera, begin withdrawing. And if you think how the economy grows, it grows based on investment. So as that large population moves from a contributing population to a withdrawing population, it's going to have significant impact on all of us in this room and how we get reimbursed. Talk about CMS. You know, I visit probably 100 hospitals a year. My team is in the hospital every single day. And we pull a lot of numbers. We're doing a lot of benchmarking. And one of the things that we're realizing is that a lot of our clients have over 50, 60% CMS patients. So the question is, can you continue to operate in an environment where you're being reimbursed at 84, 85% of what you're getting today, when over half of your population, half of your census is being reimbursed at that rate? So put yourself in the position of the CFO. Historically, his CFOs, when you know this, whenever there was a problem with economics in the hospital, the first thing that goes, head count, right? I don't think we can squeeze out any more nurses from our systems. And so from a CFO standpoint, looking at the balance sheet, 55% of the expense is labor. What's the next biggest bucket? It's us. It's stuff. We represent about 35% of expenditure, which is probably why we are now at the forefront of folks. They're looking at us like they've never looked at us before, and what we do is so much more important than it's ever been. So let's talk about a typical hospital, 350 beds-ish, has 20 to 30,000 individual stocking locations for consumables. Sounds like a huge number. So when you think about it, I could have a bandage, one SKU number, that can reside in literally 1,000 locations in the hospital. So a good example of this, we recently completed doing an assessment at a hospital we're working with in St. Louis. A large hospital has 58,900 individual stocking locations. So think about just the economics and the effort of trying to manage those individual locations. Inside of that, 80% of the stuff that you buy, the SKUs, are expendables, right? Primarily, they're the things you get from like us and from Medline and from Owens & Minor. I mean, preferably from us, but that's okay. But that might represent, what, 20% of your spend. The other side, you've got 20% of the SKUs that you're buying, which is something we call direct, things you get directly from a manufacturer. Think of expensive stuff, things that stents, and that might represent 80% of your spend. 15% of those transactions that you're doing are upside down, meaning that the cost of doing the transaction is higher than the value of the product you just transacted. It's crazy, right? And on top of that, we're big proponents of what ARM is trying to accomplish. And a couple of years ago, ARM recognized that with the unique device identification law that was coming, that RFID would play a much larger role as a means of control, track, and trace. And so think of the UDI law. As it's written today, it's primarily focused on manufacturers, right? This is the idea that a manufacturer has to know where every each is at a serial level of control to have, to know what the individual item is, its lot, and its expiration dating information. So that started, that was passed, went into effect a year ago, September, and just last month, the first wave of classes of devices came under those rules. So Class 3, Class 2, Class 1 devices over the next 5 years. You gotta believe that once that's in place, the next piece of legislation is making us responsible for knowing where those items are, especially as they go into patients. I gotta tell you, coming from where I came from, I was shocked that this was a law. I didn't realize that it was entirely possible. We had patients out there, and we did not know what the implantable was that was in the patient. And I started asking people when I first heard about this law 2 years ago, and folks said, well, yeah, we don't have a way to do it. It's really complicated. where healthcare were different, you know. I came from making cars. And I got an aside on this. I loved making cars. It was sexy, right? First came to healthcare, and at first I wasn't happy because I missed cars. Because I went from cars to like bedpans, right? But my mother-in-law is a retired scrub nurse, and she took her a long time to figure out, Master Black Belt, what is it you do? And then she started realizing I fix things, right? I have people that fix things, and I try to give guidance to the people that fix things. And I find that if you're where I'm at in your life, you learn more from the people that you think you're teaching stuff to than what you think you're doing. But she came back to me and said, hey, no, you got to go fix healthcare. So I had this sort of daunting task, right? But more importantly, the people that I met, interacted with every day, the people that I work with and the people that I interact with, my customers, I came to realize that I think what I do now is important. It feels like something more important than just, making a fancy schmancy car. But 20 years ago, I knew exactly what airbag was in what car and who owned it. And if you've ever bought a used car and then subsequently received a recall notice, that is not a new technology because every car has a VIN. The VIN number, every car is unique. And it's exactly the same principle moving into unique device identification. And so ARM has been a proponent of RFID as a means to do this. We completely agree. Quick show of hands, who uses a PAR system? We love our PAR system. Is it interesting? Oh, we don't love it? Boom, I don't like it either. We're the last industry in the world using PAR. The one before us that got away from it was grocery stores, and they did it 25 years ago. And grocery stores and it's funny, you compare what we do to other industries, and you hate to think that we're behind. How can we be behind grocery stores? But grocery stores have UPC codes. Every single item in a grocery store has a unique identification and one single barcode platform that everybody can read. I don't have to receive a can of peas into my grocery store and over-label them so that I can read them, right? We're moving to a single barcode. We can't move to a single barcode in healthcare. Why? Think of the exorbitant amount of money that we spend, and why I'm talking to you today is unleashing the value we have trapped in our systems. Think of the money that we have trapped in processes and procedures that we have to do to overcome the fact that we don't have a common barcode system. Oh, and when you scan out of a grocery store, that information is used for all kinds of stuff. It triggers a reorder. It also measures variation. Variation is evil, right? I kind of live my life on three basic principles. Batching is bad, variation is evil, and forecasting is the F word. So a lot of people are tied to their forecasting systems, and yet they're not accurate. Does anybody ever have to sit in a finance meeting and explain their variances to their budget? I realized the first time I did that, because I sat and listened, this is years ago, that I only had to know three answers. The first is, we expect it to self-correct. The second is, it's a timing issue. And the third, if I'm clever enough, is some kind of pull forward, push back because it happened in the wrong month. Right? See, the problem with forecasting is it's never right. Unless you have the availability of a clairvoyant, and I'm pretty sure clairvoyants don't work in healthcare. Right? So where's the value trapped? A lot of it's in your on-hand inventory. Like I said, you've got 20 to 30,000 individual stocking locations. So think about how it works today. Probably most hospitals work the same way with consumables. Those things are expensed upon arrival. We don't have a procedural bill of materials in healthcare. Every other industry has a bill of materials. So when I finish a widget, I automatically know what I used. I used this much metal, this many fasteners, this much labor, this much electricity, this much paint, whatever I made. We don't have that. And so my team, that'll be in doing a conversion of a clean supply room, will have gone off the customer's data and say, oh yeah, the customer's got 17 days of inventory. Wrong, the customer's got 70 days of inventory and doesn't even know it. We've attempted over the years to solve these problems by using really expensive technology. There's a particular brand of technology that we used to own. We divested in 2009. I never want to slam anybody's product, so we'll say it rhymes with Mixus. So, fantastic solution for pharmaceuticals, right? It's a great control for pharmaceuticals. But I walk through hospitals and I see toilet paper locked up. That doesn't make sense to me. But when you think about this, what we thought we would do at some point is we said, let's do this. The nurses are already in this clean supply room getting stuff. So while they're there, we'll have them tell the system what they got. It's a great idea. It's not going to cost us anything to do it. They're already there. So let's walk through how that happens. I'm a nurse. I walk into the room. I scan in or swipe in or log into a system. It brings up a screen. I select the product that I want. Now, there's multiple variations of this, but I'm going to go through a general way. Select the product that I want, bring up another screen, select a patient. Find the patient, identify the product. It unlocks a door. I go over to that door. I open it. I take a product. I probably push a button to show that I took the product. I close the door. I go back over to where I started. I log out of my session. Takes 45 to 75 seconds to do that. If I do it 120 times a shift, that's 2 hours of my day. So the most expensive people that we have, the most talented people we have in our organization, the proxy for our patient, the nurse, is spending a quarter of her time, his or her time every day, doing supply chain work. I don't think that's the best way to do it. On top of that, for some reason, a lot of us buy storage solutions. I don't think what we should be doing is focusing on storage solutions. We should be focusing on inventory management solutions to make sure that we have what we need based on what our demand looks like. I don't care that you can stock 8,500 of something if you only use 12 a day. That doesn't make sense. Expired and obsolete. Whether you know it or not, every hospital in this country is losing somewhere between 2 and 5% in expired product every single year. So 2 years ago, the Master Black Belts from Cardinal Health got to spend a couple days with the Master Black Belts from the Joint Commission. And that was interesting. Funny stories about you all, right? And they love you, right? It's funny because they get this perception that people think they're a gotcha organization, and they're not. They're simply a do what you say what you do organization. We're going to audit against what you said you do. But they have this magical way, this almost mystic capability to reach into a bin when they get there and pull out an expired product. Is that crazy? How do they do that? So shame on us that there's an expired product available for a patient. That's the crux of the problem right there. But think about how that happens, right? So, this may or may not be plausible. You tell me what you think. Nurses, you have a wide array of talent in the nursing staff, and people who work different hours, and some of them work in different places. They're fairly transient, right? So I'm a nurse that just came back on Monday morning. I wasn't here for the last couple of days. I walk in, someone says, "Oh, Jayco's here." And I freak because I'm going to run to my locker and grab all that stuff I got stashed. And I'm going to run back, and where am I going to put it? Back in the bin. But that stuff's been in my locker for a year, so pretty good chance right? Despite the fact that all of us worked a tremendous amount of overtime for the previous 2 weeks going through every single thing. And what do you do with all that stuff? I'm sure it goes someplace, right? So why did that happen? It happened because the nurse didn't have confidence that that item that was going to be there when they needed it. There is this interesting relationship between people who do what we do, and let's be honest, right? I equate what we do to kind of being, if you've ever been to a play or a concert, and you see somebody go running across the stage in black t-shirts and black jeans to fix something, that's us, right? So if you don't see the tech staff at a show, everything went right. And it's kind of like us. I mean, you hate to say that. If we're invisible, it's kind of like it's going right. I once read that the art to inventory management is to sail in as shallow water as possible without ever touching the bottom. And I talk on a different subject sometimes relative to metrics. I want to bring it up really quickly here. A lot of folks are starting to focus on inventory turns, which is great. Inventory turns can be benchmarked against industry. Concept of inventory turns is I'm turning my inventory quickly, I'm not going to expire, it's not going to obsolete, and I'm going to have a faster turn of cash, right? It makes perfect sense. But it's like a three-legged stool between capital, labor, and transportation. You can buy high-level inventory turns. It doesn't make sense unless material is the most expensive piece of your operation. It's not our most expensive piece. So just as an aside, my very friendly recommendation would be if you're trying to come up with a target, if you're being given a target for inventory turns, just beat 12, right? Target 13, try to beat 12. I have yet to see a hospital do this, by the way. No one's actually at this level. But if you did that, then theoretically, because most folks do their finances on a monthly basis, right? So you're technically, and you think about most of what you pay is probably net 30 at fastest. So you will get paid faster than you have to pay. And that's the trick to inventory turns. Any faster than that, you're spending a whole lot of money to brag. I talked about this already a little bit in terms of RFID. One of the issues with obsolete is a lack of tracking capability. And recently spoke with the VP of supply chain of a large system in upstate New York, and we were going through our inventory management offer, which is we call CIMS, Cardinal Health Inventory Management Solutions. And he liked a lot of it, wasn't convinced about some of the numbers. Called me back a couple of weeks ago, said, I've got a $25,000 catheter sitting on my desk that expired. Crazy, right? Second piece is, turns out when they did the math, they're losing 4% a year, expired and obsolete. And that's just because he's always used a number, right? Because the reality is, most of us don't understand, we don't actually record expired and obsolete. If a nurse goes to use something and it's expired, do they record it or do they just pitch it? Probably just pitch it. I'll talk a little bit about consignment. Consignment is kind of a drug. We get addicted to it because we think that, hey, I don't have to pay for it till I use it, so I can have it here and it's not on my books. So think of all the money I'm saving. So unless you are really, really good at contracting and have some kind of excellent connectivity between what you actually use at each level and how you pay, you're probably paying for stuff you never used. More importantly, that delivery method, the trunk stock delivery method, the most expensive sensitive things that you buy, the primary storage location for those items is somewhere between a snowblower and the kids' bikes, right? I don't get that. And we already know that they lose 20 to 30% every year in expired and obsolete. So I have teenage daughters, which comes with a whole host of other things, right? But when you take them, and they're wonderful, I just say that for humor. When you take them out to buy jeans, you're not getting out of there with a $50 pair of jeans, right? Teenage daughters, anyone? You get this, right? So I've come to realize that the cost of shoplifting is baked into the price of the jeans. And it's exactly the same thing in the consignment model. They have an over 50% SG&A rate, incredibly expensive delivery method, losing a tremendous amount of material every year, and that's what we pay. And finally, in terms of stocking strategies, a lot of us use what I call an emotional stocking strategy, right? Which is kind of, I'm going to put whatever I can fit someplace, or I ran out of this once in 1937. Right? Counting. So most folks in this room probably manage a staff that has to do a lot of counting. And in some inventory management methods, counting represents about half of what these folks do. So the lowest paid people in our organization, and we trust them to go out and count every day. So follow folks around and see what really happens, right? I have a bin location. We've gone through and done some math at some point around a par optimization concept and said, hey, I think we use somewhere between here and here, and so we're going to establish a min and a max. And maybe it's just for a number, min of 12, max of 24. And I expect someone to come around and count, and then probably tell a system what we have. And that, this is assuming you're not using like a Mixus, right? And then tell a system what we have, and it's going to order back up to a number, right? But you got 20 to 30,000 stocking locations if you're 350 beds, and more if you're bigger. So here's what really happens. Min of 12, max of 24, I can fit 50. So here's what I'm going to do. I'm going to zero that baby out and fill it up, and I'm going to start looking at it once a week. Now, what I'm expected to do when I come to replenish it is to bring the stuff that's coming in and put it in the back and pull the old stuff forward, right? What's that called? We call it FIFO. Stands for, what's the opposite of that? Fish. First in, still here. So even the Mixus system, where I've got nurses now spending 25% of their life doing supply chain work, we've actually had to come up with I'd never heard of this metric before, called compliance. You heard that word, compliance? Compliance is the metric that we measure between what our system, our MMIS, we love our MMIS, what that system says we have on hand versus what we actually have on hand, and whatever the delta is, we blame on nurses for not doing their job. It's hysterical. So I've had VPs of supply chain say, you know, Steve, if the nurses would just do their job. Recently I had someone say, we don't have a problem. Our compliance is really high. I said, that's really cool. I have never seen 100% compliance. Can we go see it? And he said, well, it's not 100, right? It's 90-something. And in the back of my mind, and I always got to be careful where it stays, right? So in the back of my mind, I thought, it doesn't really matter then. Whether you're 90% compliant or 30% compliant, you still got a cycle count. And so the question is cycle counting value add? Anyone? No, it's never value add. We cycle count only because we don't have a workable solution. So then, even if you have to cycle count, what's the right frequency? People ask me that all the time. What's the right frequency? I contend it's never. You should never have to cycle count. There's a much better way. We learned it from a company called Toyota in the 80s. Came to North America in cars, and now it's everywhere, and it's starting to come to healthcare. So another quick show of hands. How many folks have heard of, are doing, or are contemplating some sort of Lean or Six Sigma in their facilities? Yeah, more and more. That's great. How's that going? Good? You people like it?
Getting there.
What he said, getting there. What do they like about it? Do you know?
What do I like about it, or what do they like?
Well, okay, so here's my philosophy is, especially Lean, it's very folksy, right? It's designed for the people. But what do you like about it first?
Standard work,
Love it.
higher reliability.
Oh, you're making me tickle. Okay. Here. And your people?
I think they trust us enough to know that they're not going to lose their job.
So it's interesting, right? When it first came to North America, so in 1982, 83, quick history lesson, every car company on the planet lost money. And for those of us who are over the age of 50, we remember that intimately. I was just going into college, and suddenly I was facing 20% student tuition hikes and 20% interest rate on a student loan if I had to go that way. Got real lucky. I got stupid lucky, and I went to work at a GM facility that happened to be one of the very first places that the contingent came when they came back from in 82, 83, when all this happened. Toyota opened its doors and allowed the United States the government of the United States and Canada, who at the time were the two largest car manufacturers in the world, plus Ford and General Motors, who had a long history. Alfred Sloan and Henry Ford had a long history with the Toyota family, had bailed them out when they went bankrupt in the 50s. And Sloan School of Business and MIT sent all these academic types to Japan. They spend a year and a half there learning the Toyota production system. That's what we called it. Toyota didn't call it that. It's just, to them, is our production system. In 1989 at MIT, while studying all these phenomena, someone there named it lean. That's where the word came from, where lean came from. In Big Auto in Detroit, the first time that labor heard lean, what they heard was an acronym for less employees are needed, right? That is not what lean is for. Lean is supposed to create capacity, right? Now, obviously, and it's generally what you're doing is finding waste. You might truly have a condition where you've got 50 people doing what 12 people should be doing, and that presents an interesting problem. What Toyota did when it first embarked on this concept was it made a commitment to its labor that it offered jobs for life. I don't think that's a practical thing anymore, but what they were able to do is use their existing infrastructure and double what they did, and that's what lean is intended to do. So, when your folks here were worried about our jobs, it's an interesting place to be, where you can actually say you can make certain commitments, right? And what we've always told folks is we're not going to do any job reductions, any reduction in force related to this work that we're doing. At the same time, there are forces that happen outside of us that we have to be aware of. So it's important to make sure that people get fully engaged. Here's what I love about lean with the folks. It's folksy. People get it. It's counterintuitive at the beginning, and after a while it makes perfect sense. More importantly, what we do is we drive decision-making to the lowest possible point in our organization, and that's what we really want. I don't want to be getting called in the middle of the night to try to answer questions that people should be able to know the answer to. Let's talk about freight. You've probably already figured out I'm an oddity in some areas. One of them is I don't sleep. I just always I try to sleep, but then, there's TV on someplace in the house, and I hear way off in the distance that if I call right now, I can get a second one absolutely free for just shipping and handling. And so I go over and look at that, because it was $9, seemed like a good price. I can get a second one for just shipping and handling. And then when I get it, it's never quite as fabulous as I thought it was going to be when I saw it on TV. But it was 3 o'clock in the morning, can't blame me. But I paid $80 for it with all the shipping and handling, everything came in. And I came to realize, holy mackerel, that's our industry. So, GPOs have done a pretty good job in some of these areas. And we've done a pretty good job in some of these areas. But, I still see a whole lot of this idea of total landed price. I want to know what the total landed cost of something is. And if it's coming in prepaid from a vendor, I don't get to see the breakdown of what I'm paying for an each versus what I'm paying for the trans. And I guarantee you they're margining the trans. That's what I would do, right? So as a GPO or someone is able to negotiate a penny off the each cost, I'm still margining the trans. So that's one piece of it. Here's what industry does. What large industry does is it wants to know just the each price. So it's going to receive everything at the each, and it takes over responsibility for transportation, because what they want to be able to do is to be able to aggregate all the trans to get to a better trans cost. And more importantly, to see what the actual pennies are on the trans. But even if you did a great job of that, somehow when I walk through your buildings, and I do all the time, I see stickers on boxes that say things like next day air. And yet the box was received 2 weeks ago and has not been opened. And who paid for that? Right? So, transportation and freight is something we've got to give a lot of thought to. And again, let's go back to why we're talking. This is where the money is trapped. We're always looking for the big silver bullet. There's no big silver bullet. It's a series of shrapnel, right? This is one of the pieces. We're spending way too much money on transportation. We talked about this already, but there's one other piece I want to talk about. Wouldn't it be nice? We have a UDI law in place now that says a manufacturer has to have visibility to their eaches, to every one of their eaches as they enter through distribution or whatever mechanism you get things. Gotta believe that in 5 or 6 years, you're going to be held accountable for for retention of that data electronically, right? So think of EMRs. I think the pencil's going away in our business. And so wouldn't it be nice to be able to receive an item that the manufacturer has already tagged and has that information, have it come through whatever mechanism, whether it's through a distributor or through your own network, to be able to come into your building, have visibility of where those eaches are, all the way to your point of care, so that you as the ultimate customer, and regardless of where ownership changes hands, right? Whether it changes hands when you use it, or ownership happens when you first bring it in, or somewhere in your middleman has it, that's not important, that's just negotiated. Be able to see the visibility to where all of your eaches are from your patient via the proxy, which is the caregiver, all the way back to the manufacturer. Something we don't have today. Not true. Something most of us don't have today. It exists now. That's out there already. We've been doing it for about a year and a half, and we're expanding the platform. So I talked about this. And it was supposed to be hysterical when I said it, right? But to think of the storage location, and I know this because the guy who lives across the street from me is national sales director for a huge stint company located in the Midwest. And guess what? He's got a pallet sitting in his garage. A pallet of really expensive things. And in fact, here's what he did. They put steel doors on the garage, multiple bolted steel doors with an alarm system just for the garage. So there you go. At the end of the day, we take our HCAP scores seriously. HCAP scores ultimately dictate what we can charge, right? And in the future will also impact how we're reimbursed. And so think about, so I have a son, my youngest, my son, is a travel hockey player. Excellent hockey player. Was a pretty good hockey player when we lived in Canada, moved to the US, turns out he's really good, right? It's DNA. So we know the local ER really well. We're in there from time to time. And at the end of him doing a visit, we receive this questionnaire. And the questionnaire, when you go through it, and I do it for him, we do it together, I suppose. I simply said, hey, was she nice to you? Because what the questionnaire is really saying was my nurse nice to me? That's really what it says to a lot of people. So think about most patients' experiences. They don't understand the clinical aspects of why they're there. We've already established that the nurse is spending 2 hours a day doing supply chain work, is probably frustrated by that, or is using a different system where they're running around from locker to locker looking for something. And so do you really believe that that nurse is in the best frame of mind when they're caring for the patient? More importantly, we know from TCAB, the Transitioning Care at the Bedside, which is a national nursing initiative, which I really support because they've actually done the math. There's a correlation between time spent at bedside and quality of convalescence, right? Likelihood of patient readmitting in 33 days after a procedure is reduced by the amount of time that the nurse spends with them at bedside. You buy that? Because guess what? The stats tell you it's true. What happens if the patient readmits in 33 days? Or more, what doesn't happen? You don't get paid, right? Never events. And so, sentinel events. And so, think of these three things sort of happen together. If you've got an incapable supply chain mechanism to bring things to point of care, and your nurses are struggling to find things, and it's impacting their how happy they are. That's going to reflect on what happens with the patient. Because you think about why patients readmit, it's generally because they didn't take their meds correctly. They didn't do their dressings correctly. The basic stuff we weren't able to do because we didn't have the time. So what can be done? Famous coach, right, made this comment, which I read recently, and I kind of adapted to this thinking. You know, I meet a lot of folks who call and say, hey, we know what you're doing, we know what you're working on, really like the idea, can you show it to us? We take them through it and say, wow, that's really big, I don't know if we can do that. We're going to do this instead. And so here's my guidance. If you're going to make any kind of a change, whether it's an MMIS or you're going to implement Epic or CERN, or you're going to make any kind of large-scale change, think through all the implications, because every time we do something like this, it's a huge expenditure, right? So we're going to be depreciating this baby over 5 years, which means we're married to whatever we did for 5 years. So if it doesn't get us to, if it's not quite right, we're stuck with it. If you haven't got the time or energy to do it right now, are you going to have the time or energy to do it later? And the answer is probably no, because you're already stuck with what you got. Talked about the three-legged stool. Another thinking point. This is one of my favorite thinking points, actually. You know, we always have this idea of whether something's good or bad. Is it within specification or is it not within specification? So there's an inflection point, again, where something happens perfectly. And when it happens perfectly, it is the least expensive way to do it. For example, let's say we're scheduling a procedure and we bring in something really expensive for this procedure. And we order it 2 weeks ago, and we need it. We're targeting Wednesday for a procedure that's going to happen on Monday. We want to make sure it gets here. So if the thing comes in really early, I bought it early, I'm spending labor on it, I got to put this in place, I got to lock it, I got to do all those things that I have to do with it. If it comes in late, obviously it's a bigger problem. I probably had to cancel the procedure. That's never happened, right? If it comes in right perfectly on time, that is the best scenario. So don't think of something as being on the low specification or high specification as being good or bad. The further you get away from perfect, it costs you money. It's called a cost curve. So something can still be right, but it costs you more energy, time, and money. And what I find is a lot of folks are living in the cost curve. We've identified it as being right. It's okay, but I have to put more energy into it than I should have to. And so what I'm not seeing is the amount of what's costing me to do that. So the answer is you can actually simplify and eliminate and fix a lot of these issues, partly by just adopting things that we've learned from other industries. We built it's going to sound salesy, I'm not actually a sales guy. We built our SIMS platform specifically looking at this, which says we recognize that there is no one-size-fits-all solution, right? We can't just simply buy an expensive locked cabinet and then put our toilet paper in it. That doesn't make sense. It makes sense for some stuff, not for other stuff. If you've ever tried, is anybody trying to use a Kanban? How's it going?
Not yet.
Not yet? Well, I want to talk to you. How's it working?
We're just getting started. We're doing a 2-bin that we're rolling out our first nodes next week.
Terrific. Okay. So with the differentiator between a par and a 2-bin Kanban, which a lot of people don't understand. So with a par, you're ordering back up to a level, assuming that the level that you're ordering back up to is correct. And you probably spent a whole bunch of money once upon a time doing a par optimization, right? Which means you went through and calculated those 30,000 individual stocking locations based on average daily usage. Averages are lies, right? Averages are lies. If we were here all day, and trust me, I can do this all day. So if we were here all day, and all morning you were complaining that it was 40 degrees, it was so cold. So at lunchtime I turned up the heat, and all afternoon you're complaining because it's 100 and it's so hot. I'm going to say it's an average of 70. What are you complaining about? Right? 1984, University of North Carolina, geography majors. The average starting salary of the graduating class was just over $865,000. It's a fact. Anybody know why? It's probably not because you want to go in geography, right? Who graduated in '84 from UNC? Jordan, right? So if you think of what that distribution curve looks like, it would be like something like this, and then a blip. And no one actually made the average, because you had Jordan way over here making a ton with all their endorsements, Because you remember what happened. He got hurt and went back and finished his degree, right? So averages are lies, which is why PARs are a problem. The other problem with a PAR is it doesn't take into account simple things. So we look at forces of variation, and so this is free help as you're setting this up. Forces of variation. If you go to, say, Boca Raton, Florida, in July, and you go to a hospital there, they're going to have a census of 75%, median patient age of maybe 55, and those folks are presenting with the disease states they present with. Leap forward to November, same hospital, right? So now you're at census of 100%, median patient age of 75. You've had to ramp up your staff, so you're bringing a lot of external folks in, folks who live in Wisconsin and Michigan in the summertime, or Virginia, and then live in and work and live in Florida in the wintertime, and they bring with them those 35 years of experiences, which means they're really, really difficult to, from a professional practice standpoint, it's difficult to get them into your way of doing things. So they're entering more variation, and then all of a sudden the flu hits, and we're always surprised when the flu hits. Have you noticed that? We're always surprised when that happens. So the problem with PAR management systems is it's not dynamic, and you're ordering back up to another number. The second problem with it is you're always creating a tremendous amount of variation in your order patterns, because one day you order 11, then you order 13, then you order 9, then you order 41, and so the beauty of a Kanban is you're only ordering when it's empty. So the order, now you've standardized it, and if you're doing it right, you should be looking at the order. At the sizes that the items come in at. What's the logical size that something comes in at? So if your math says there should be 10 eaches in a bin, but they come in 14 in a package, and they're not very expensive and they fit, just make it 14. Because the other thing you're going to get is a perfect FIFO. So when we built this, we looked at the Kanban for the really inexpensive stuff, all the way up to the RFID. We knew because of ARM and because of UDI that we needed to have an RFID capability, because you're going to be looking for that, and then you're probably looking for it already, depending on where you're at. We actually got funding to create an RFID mechanism, went out looking at best practices, found it in a company called Wavemark, and bought it. Wavemark, from our perspective, was the finest RFID company on the planet, and actually half of that business is the manufacturer-facing piece, which they've been doing for years. So the manufacturers are already RFID tagging at an each level. And those hospitals that are on this platform now can bring those RFID tagged items through distribution, so it already exists. So that's where a lot of your money is trapped in your supply chain. And the title of this was Unleash It. So you can unleash that value by just going out and looking at it with a different set of eyes. It's there. Questions? Yes, sir.
I've got a question. I'm still trying to get my arms around what you said about inventory management and cycle counts, and I've been around for quite a while.
Mm-hmm.
I can tell you, in our health system, we are still doing cycle counts. The combine system, which we have had some conversation around, to me seems very much like the exchange cards that we did back in the 80s. Then we all stopped doing exchange cards because we found out we were doubling our inventory value and went to the PAR scenario, which interestingly enough, back in the day, Cardinal was out there really telling everybody you needed to have.
We did. We sold
those systems. Now
we did. Yeah.
Use an open system like I know some of the others do.
Mm-hmm.
But we do still circle around and we do still cycle count. And we've had a lot of conversation around what's the right way or the wrong way. Just out of curiosity, I know there's some other health systems that are sitting in here with us today. Are others still cycle counting inventory using PARs, or have you totally gone in a different direction?
I would say most are. Most are still doing it. Some have stopped. So there's a huge difference between a Kanban and an exchange cart, right? Because the other problem with the exchange cart is a tremendous amount of labor in just managing the exchange cards. Kanban is basically self-replicating. And you're right. 10 years ago, someone who looked just like me probably sold you a really expensive closed cabinetry system. Recognize that 10 years ago, you were being paid based on things that you billed for. That stopped. That is stopping, and so the world has changed, right? That made a lot of sense back in that, and because of the economics of how you get compensated. Makes perfect sense. You can tie items to and eaches to patients. Today, with bundled reimbursement, the story's gone away. We find, we did the analysis with a large system in Houston, Texas, and they came back, and we'd also did the same thing with a large system in St. Louis. Both came to the same conclusion. They were spending more money on accounting in the non-procedural areas than what they were actually getting reimbursed for doing patient chargeables. And so we just got out of the business completely. Recommend you take a look at it. You're probably doing the same thing. The difference ultimately between PAR systems and Kanbans is the counting piece. And so if you want, after this, see me on the side, I'll give you recommendations, or I'll give you references of folks you can talk to who have gotten out of counting by moving to a different kind of a system. But it's counting not just because of the labor involved in counting. Counting because anyone who's ever done a physical inventory knows this. You create as many problems as you fix, right? Whether they're fat finger problems or they're unit of measure issues. Kanban and exchange cards, not the same thing. And I kind of thought the exchange cards were kind of cool when I first saw them. So, until you actually get in and do the mapping around how much labor is involved in doing it. Tremendous amount of extra labor. And it's funny you say, because essentially what you've done is you've doubled. The difference between a Kanban system and exchange cards, one of them is that you don't actually double your inventory with a Kanban system. We typically see a sustained reduction of 35 to 50%. In on-hand inventory, moving to a Kanban system. At the same time, seeing a significant improvement in first-time fill rate and a reduction in stock out. Because what you've done is you've basically mirrored your replenishment system to your utilization. Thanks. Other questions? Well, thank you very much. I enjoyed being here today. I know I'm the only thing between you and lunch, so I know my place. So have a great rest of your day, and thank you again.